be able to see the screen.
You should hang around. I need the help. Anyway, so we could, before we start, can I just welcome you, Professor Gowhar Wajid, to this very important webinar of Sadiq International Virtual University. Sorry it's been a little delay because Sakina is busy elsewhere. She had a meeting somewhere, was traveling. Now, Professor Gowhar Wajid doesn't need any introduction. So let me just, so you're there. He's a world-renowned medical educator. He has done so much work in the last 25, 30 years, maybe more, without disclosing his age, in developing universities, developing health professional programs, health education certificates, diplomas, and he's currently working as the technical director, medical education director at the WHO, based in Cairo, but he travels extensively. The entire Middle East, about 19 or 20 countries are in his domain, and he travels regularly to Pakistan and to England. I met him recently when he was visiting, and we had a wonderful little chat. He is always generous and kind. He's also the senior member of the academic board of Sadiq International Virtual University. We seek his advice in most difficult situations, always helpful and extremely kind and generous. Over to you, Professor Gowhar Wajid.
Bismillah ar-Rahman ar-Rahim. Thank you so much, sir, for your very generous introduction, and welcome all the participants. This would be a brief talk at my end because I want to listen to all of you as well on this very important, very fundamental, very basic subject that we all face in our educational arena on daily basis. First thing that makes us always it's the talk of the town, talk of among educational communities about reforming the curricula. So I have always been asking me, what does actually curriculum reforms mean? Then recently, I was in Saudi Arabia on a talk on interprofessional education, how to integrate interprofessional education in Saudi curricula. So if we integrate interprofessional education in Saudi curricula, undergraduate or postgraduate, whatever, then does it mean that their curriculum is reformed? Can we just integrate interprofessional education approach, collaborative practice in a curriculum, and maybe say now our curriculum is reformed? So how should we approach curriculum reforms basically? So these are some of the things that I'll be discussing here. These are all my personal views based on evidence, nothing to relate with my present organization or even past organizations. So in this presentation, I'll be touching upon some of the issues, very crucial issues that we are facing today, is the transformative changes that are happening around health professions education, in the context of the complexity of health and education systems. Then what should be health systems response to the needs of the people, and the strategic shift that we are seeing towards community-based, competency-based and interprofessional education. Then the significance of interprofessional education and collaborative practice, I'll give you some examples, and then leave you with some key considerations to bring the actual curriculum reforms in your curricula. So this is the context of this brief presentation. There was an article, rather report published in the Lancet 2010, led by Julio Frank and the Lancet Commission team that addressed the health professionals of a new century, transforming education to strengthen health systems in the interdependent world. And the report says, and need not to say, we all know that health professions education has undergone significant transformation. This was 2010, and still it is undergoing significant transformation now, the latest impact of artificial intelligence we are seeing. But all this is happening in what we call complex healthcare systems. So while we, being educationists, are focusing on educational reforms, we in most cases do not see these reforms in the context of complexity of healthcare systems. So that's where I will be discussing my views about. So my fear is that our isolationist approach, our micro level approach, even about major educational reforms, it does not holistically include what should be the quality of education, what should be the number of the graduates at all levels, and I mean all graduates, including medical nurses, pharmacy, dentistry, allied health sciences, etc. And most important of all, even more important than quality and quantity, is the relevance of education. No matter how good our health professionals are, no matter how many we have, if they are not relevant to the needs of the communities, then no matter how good they are, they may not be able to play their roles effectively in the communities, in the countries, uh, to the needs of the people where they are serving. Now, before we look into what are the needs of the people and how to transform our curricula based on the needs of the people, we need to have a holistic picture about the overall healthcare system that we are a small part of, and not to forget that whether be a medical college or a nursing college or a postgraduate medical institute, it has to be seen in the context of the overall healthcare system, which in turn again is working in a complex socio-political and geostrategic system. Just take the example of the things happening in our EMR region. Think what has happened in Palestine in recent days, and what is happening in Lebanon or Iraq or Afghanistan or these countries. The way things are different in these countries based on their geopolitical and socio-economic conditions, that all of them, they add complexities to the overall system, and eventually they impact the healthcare system as well. So whenever we talk about curriculum reforms, we need to have a holistic picture about what is happening in our country in the overall context of the country. That's where the value of contextualization also plays a very important role. So now, talking of the two systems, I talked about the complex nature of the healthcare systems, and not to forget, then there is a complex nature of education system as well. So what do we basically mean by when we say that healthcare system is complex and we need to take care of the complexities of the healthcare system? Uh, this is general common knowledge that healthcare systems are complex. And what do we mean by the complexities of the system is that there are so many variables that are playing an interactive kind of roles. There are so many stakeholders. There is very tight coupling, what we call, among the parts of the systems. They are all interdependent, which means that one part is dependent on the other part, and the way the other part will behave, it also depends on the behavior of the first part. And despite, even if all the parts they work in a perfect manner, even then you cannot say that you will be able to achieve the predictable outcomes. So outcomes are often, they may be unpredictable. So all these things, they make a healthcare system a complex system. Now, not to talk of that not only the healthcare system is complex, health system is complex, but at the same time, education system is also complex. The same variables of complexity they apply to the education system as well. And then think of then health professions education, how complex the task could be, where the two complexities not only add on to each other, but they actually multiply with each other. So, with this background, if you have realized the complexities of how complex the systems could be, health professions, education systems, how complex they could be, now I would like to draw your kind attention to identifying the needs of your communities for which you are producing health professionals. And again, this diagram is taken from Julio Frank's Lancet Commission's report. I recommend you all to read this report. This is very useful report when it comes to transforming and scaling up health professions education systems. And the report says that whether it be education system or health system, we must keep in mind the needs of the population for which these two systems are being developed. So the central tenet is the population or the communities, not even the patients, because patients are just one part of the overall population and community. So that's how the complexity then adds into. And the very first thing we learn is that our curricula should address the needs of the populations they serve. If they are serving the needs of the population, they are relevant to the needs, they will produce the kind of health professionals that are useful. Otherwise, they may not be as useful and productive as we expect them to be. Now, when we have said that these are the needs of the populations, keep in mind that transformative changes, they require a fundamental shift basically. So what do we mean by when we say curriculum reforms? Oh, we are in the process of curriculum reforms. So I have seen, oh, we are reforming the curricula. So what are you doing? We are adding some topics, some new topics to our curriculum. We have added one module on patient safety. We are even converting the curriculum from annual traditional curriculum to integrated. Now what's the level of integrated always remains a question, but on semester system and modular curriculum. So we need to ask ourselves, is it really, when we convert the curriculum from traditional system to modular system, is it really transformation or just a transition? While actually the subjects and the topics have not changed, the content remains the same, the format of the delivery of the content is changed. So do we really call this change as a paradigm shift or as a reformative kind of change? One way of looking at the change is where we reform the curriculum, we transform the curriculum from a typical disease based, illness based, physician centered, hospital based systems to what we call wellness based system, that is patient centered systems, or community centered system is a better term that personally I like. That's not hospital based versus then we go for you can all of you are very familiar with Harden's spices model that provides a basis of strategic shift when we want to actually transform the curricula. So that's where when a curriculum starts shifting away from the disease to promote promotion, maintenance, and restoration of health model, then that's what we call the kind of paradigm shift that we are looking in terms of our curricula. So when we say that we are going to introduce, for example, interprofessional education, we need to see it in the context whether interprofessional education will actually transform the curriculum to the levels or reform the curriculum up to the level that we are expecting the curriculum to happen. Now, the simple example is that if you have a disease-based curriculum or illness-based curriculum, and still you introduce interprofessional education, is it going to be really transformation or mere a transition where you have um, integrated a very specific approach to achieve maybe better patient outcomes? But what about the communities to which actually the curricula should be shifting? What about primary care strengthening compared to hospital-based approach? So all these things we need to keep in mind when we are looking for real transformations in the systems. Now, if we have decided that, look, we really need to bring transformative changes to our curricula, to our education system, and we have seen that these changes are actually happening around and in the systems, then we should also start looking for alternate ways of education as well, where traditional structure and process-based approaches and frameworks may not work in the given digital and artificial intelligence era. We have to look for the alternate ways of education and training of our graduates as well. And when we are looking for all these things, then that's where probably the very first need is to see how best your curriculum serve the needs of the communities, of what we call community-based curriculum or community-based education or community-oriented curriculum, whichever the term you use. The baseline is that the curriculum should be able to fulfill or relevant to the needs of the community. So that's what we call a community-based curriculum. Now, think of that a curriculum is interprofessional education based, but it is not community based. So what kind of reforms these will be? Keep in mind that bringing reforms is not an easy task. So whenever we are bringing reforms, it has to be a holistic approach rather than an isolationist approach. So you need to, just like we see the patient holistically, not from just one disease perspective. Similarly, when we are addressing in Abraham's language, then the diseases of the curriculum, all these diseases have to be seen in a holistic pattern rather than in isolation and in silos. So first tenet that comes is your curriculum really community based? Then comes when community needs or curriculum needs need to be addressed through the community are identified. Then comes the question of competency based education, that the curriculum that is community based, we have identified community needs. Then are our doctors and nurses competent enough to fulfill those needs? So the needs are identified, and we are producing competent health professionals that can address the needs of the community. So community-based education or curriculum, then it goes in hand and very well aligned with the competency-based education. Imagine we have identified the community needs, but we have not correctly identified the competencies of the physicians that are needed to address those needs. Again, we will not be producing the outcome, the kind of outcomes that we are expecting. So here comes then the questions. Which competencies are needed to address the community needs? Who decides about these competencies? How are these competencies going to be achieved? The whole curriculum process. What is the relationship between the competencies of different health professionals teams when they are working in the form of teams? How do their competencies interact with each other and complement each other? How competencies influence the complex healthcare ecosystem, and how individual competencies transform into team-based outcomes. Even if you have individually competent doctors, specialists, nurses, lab scientists, if they do not work in the form of a team, again, the expected outcomes we may not be able to achieve. So that's where community-based education merges with competency-based education, with some of the crucial strategic questions that need to be addressed whenever we are addressing the curriculum. And these are the questions that are mostly addressed in the outcome-based or competency-based models or frameworks that we have seen, whether you talk of tomorrow's doctor by GMC, or you talk of the Canadian model of ACGME, or you talk of Saudi Meds, or there is ACGME competencies model. So all these models, they provide us some kind of basis on how competency-based education should be well structured around to create those rounded health professionals that should be able to fulfill the needs of the communities. So up to now, I have shared my ideas about community-based education and then competency-based, the need for competency-based education. So both of them, when put together, you will have competent health professionals that are able to address the health needs of the communities. But is that enough? I see these two attributes as two good attributes of any curriculum that must be there as a basis of curriculum formation. But then we come into the team-based practice that all these professionals who are competent and community-based, they should be able to work in the form of teams as well for the patients. And this process should start right, it has to be integrated in the curricula right from the beginning, so that when they are educated in interprofessional format, they are able to have collaborative practice around interprofessional education as well. So the third important element that helps us to create those effective teams that are competent and community relevant to the needs of the community, and they're able to work in the form of teams to give us a curriculum that is community based, that is competency based, and that is interprofessional education based. So this is, for the time being, my definition of the curriculum, and this is what I call curriculum reforms. Now, a little bit more elaboration of interprofessional education, where its aim is to prepare the health professionals at education level, the students, for deliberately working together to achieve those common goals that are building safer and better healthcare systems. So again, we are trying to resolve those complexities of the ecosystem that I talked earlier. If we are able to work in the form of teams effectively, we are able to address at least some of the issues of related to the complexities of healthcare systems. So this is how it happens, that teams-based models of care, you put the patient first. Basically, I put the communities in the center because I take patients as the part of the overall community. So in IPE, the students learn together. The learning context revolves around the patients or the communities. And when we get into the collaborative practice, all the health professionals, they practice in the form of teams, effective teams, to produce a desired outcome that revolve around the patient or around the communities. So basically, when we talk about the communities, what we mean, the application of IPE is that we are talking about strengthening primary care services where all professionals, they are taken to the primary care levels to connect them directly to the communities they are serving, and they have to do it in the form of a team. Now, the evidence for it, for the evidence for all of it, it's not me who is saying it. If you read the recommendations that are given in the Lancet Commission on Education of Health Professionals for the 21st century, you will see that it says that institutional reforms should adopt competency-driven approaches like CANMEDS and all those names that I mentioned earlier to their instructional design and adapt these competencies to rapidly changing the local conditions, that is your community-based education, drawing on the global resources. Yet it has to be global because the global context, the larger community context cannot be ignored as well. And COVID-19 is a perfect example of it. uh, we saw where global efforts were needed to control the pandemic. And then promote interprofessional and trans-professional education that breaks down the professional silos while enhancing collaborative and non-hierarchical relationships in effective teams. I think there are 10 recommendations that are worth reading in this paper that is available freely. It's open access paper. You can easily download it from the internet, where it says that this approach is the one that is recommended and that is needed. So a bit more elaboration of interprofessional education. I'm not going to get into the details of these different models that have been developed around the competencies that are required at the interprofessional level. So again, that's why competency-based education is needed, because when you talk of IPECP, you will need to identify the competencies, the individual health professionals' competencies, and the team-based competencies that are needed among all health professionals. And these competencies that eventually lead to quality improvement within the context of the resources uh, uh, in a particular context of the country that we are addressing. Again, there are so many models: the American model and the Canadian model and the Australian model and the British model to address how to integrate IPECP in our curricula. But keep in mind that it's not just interprofessional education that needs to be integrated. Rather, at the same time, you need to keep in mind the community and population needs, like this model that clearly states in the outer circle. If you see, it says community and population oriented, and then the inner circle says patient and family centered. So patient is one and family is one within the context of the community and population based approaches. This is University of Toronto model. There are so many models you will find on the internet. We are not going to discuss these models here. There are competencies, different groups and institutions have defined their own competencies. That is perfectly fine as long as they are there and you know how to achieve them. This is fine. This is WHO model or framework for action on interprofessional education and collaborative practice from the education level going into, it's a continuum at the undergraduate, postgraduate, and then CPD level to enhance patient and community-based outcomes. So personally, if IPECP needs to be designed in a country, then this is the model by De Armour and Ondernessen in 2005 that I personally like, because it provides you a very holistic picture of identifying the system level factors at the macro level, then institutional level factors that are at the meso level, and individual level factors at the teaching faculty level that are micro level factors that you need to consider if you need to bring curriculum reforms, not only in terms of interprofessional education, but in terms of making your curricula more holistic, community based, and competency based, and not to forget about hard and spices model that provides very good guidance on the strategic shift in the curricular strategies. But then this model identifies and gives you a systematic approach on how to look into these factors to think about the factors, the challenges, the SWOT analysis, the four-field analysis uh, at the macro, meso, and micro levels to integrate curriculum reforms at the national level in a country. So we are talking about a country level, not just an institutional level. So I will leave some food for thought for you at this point and end my talk because I want to listen to you as well. When we talk about curriculum reforms, and then we need to consider some factors that will impact the planning process, how to identify the community needs, which is community-based education approach, identifying the relevance and community needs, and then how to identify the competencies that are aligned well with the community needs so that we can produce competent doctors and nurses and other professionals. Then how to integrate interprofessional education in your curricula? Who are the key stakeholders involved and what are their roles at the macro, meso, and micro levels? Then what are the current regulations, policies, and practices in a country that provide you the basis for bringing these kind of reforms? Who is going to do the advocacy for community-based, competency-based, and IPCP-based curricula? What is your national policy and plan for reforming your curricula? How the development of guidelines, even if you have the strategic outline is there, the framework is there, the model is there, if the institution and faculty oriented guidelines are not there on how to implement these reforms, again, you may not be able to achieve the desired outcome. And last but not the least, then we come to faculty development itself. You might find, and there is always some resistance from faculty on why this change that needs to be addressed through very robust faculty development programs so that based on the regulations then you can achieve the desired outcomes in your in reforming your curricula. So ladies and gentlemen, this is my concept of bringing curriculum reforms and seeing everything holistically from community based to competency based to interprofessional education based curricula if we need to bring real reforms. Thank you so much for patiently listening to me, and I'm open to any reflections and comments.
Thank you, Professor Wajid. Exceptional talk as always. I mean, we learn so much from you every time. You bless us with your time and your efforts and your expertise and experience. We learn new things. So let me initiate this debate with two simple questions, which basically are intended for learning. So this competency-based education, how is it different from the community, or no, not competency, community-based education? How is it different from the original program that was started in 1990s called community-oriented medical education, which is called COMB? I was part of that program, so it still reflects in my hindsight. So this new concept that you talked about, how is it different in terms of practical applications? That's the first. The second thing is that when you start implementing these various curricular changes, if you have several institutions in a country, who decides which institution and who's, like, for example, in India, Pakistan, there are hundreds of colleges in India and Pakistan, in Iraq. I was looking at the list of your participants, about 18 countries are participating. So every country has different. So who has the authority? So if you can kindly advise and dilate upon these two issues. And then we'll open the forum. The learned scholars, they can ask you questions.
I will very briefly respond to the two questions Professor Zaidi uh, has asked. Community-oriented education. Honestly speaking, I don't want to get into the academic details of what is community-based education and what is community-oriented education. I think if we decide about the significance of it and we understand why it is needed and the baby needs to be born, once the baby is born, whatever the name you want to give to the baby, I don't mind at all. The concept of community oriented even started before 90s when I will link it with the Almata Declaration that emphasized primary care services. Then, when primary care strengthening model started early in 1978 Almata Declaration, that's where the educationists of that time they felt the need that we need to produce the health professionals that are designed to the needs of the communities. So that's where community based the concept of community based education started emerging. Later on, community oriented education, the conceptual difference, one conceptual difference is that implementation of community based and taking all the students practically to the community may not be possible. It has its own logistic and administrative barriers. So in community oriented models, those models of communities, the basic primary healthcare center, I have observed some medical colleges where they say that it's very difficult for us to take the students all the time into communities. So we have created our own model of a primary care center that we used to create them. And that's what they used to call community oriented education, where it orients the community, but not exactly it is community. This is exactly what gives rise to the second very natural question that Professor Zedi has asked, that there are over 1,000 medical colleges in India and I think 500 or 1,000, whatever the number, and 130 medical colleges in Pakistan and so forth. How do we standardize the things? So the policy is decided that we need community-based education, and then the stakeholders very carefully identify those competencies that need to be seen in the doctors or in other health professionals. So once the competencies are identified, that's where competency-based medical education plays a role, with the essential difference that in the traditional education, these are the subjects that are important and the content that is important, and we take them forward. But in the competency based education, then we define the outcomes and competencies first, and then we decide about the content that is needed to be taught in order to achieve those competencies. So once, if there are 130 medical colleges in Pakistan, then the regulatory body of Pakistan, which is Pakistan Medical Dental Council, must identify the competencies, lineate them to all medical colleges. Look, this is the product that we want, and you are the factories now, and we want exactly the same product to be produced through your medical colleges. So that's why competency based education is important. I guess it serves the purpose. Any other questions or comments? There is a question to develop community-based curriculum. Faculty capacity needs to be built. How to suggest? Absolutely. This is one of the very important crucial points that we need to have robust faculty development programs. See, community-based or whenever curriculum reforms are needed and curriculum reforms, we need to have a robust strategic plan. That strategic plan must be aligned with the operational plan. Guidance documents have to be there, and a robust faculty development plan has to be there. So without having a robust faculty development program that builds the capacities of the faculty to address the issues of the faculty on how they are going to achieve competencies, the programs are likely to not succeed if it continues.
So Sadia
Thank you.
Shahzad, Sadia, would you like to unmute yourself and put your comments directly? And then Dr. Arshad has raised hand, so maybe after that it'll be Dr. Arshad's chance. Sadia and Simon
Prof.
Batul.
Zaidi, me also.
Yes, hello Shahid, very seasoned.
Hello.
Thank you so much. Thank you so much for taking me on. Thank you, Gowhar, for answering my first question regarding the capacity building of the faculty. My own take on this is that we are talking about development of community-based curriculum, but our faculty at this current moment is not ready to take it on practically because their own capacity in this regard is not developed as yet. You were talking about primary health care right now. Primary health care is implemented in Pakistan, but actually, what we are imparting to the student is just a little bit of theoretical knowledge to the students about primary health care, and there is no practical involvement of the students in primary health care and through primary health care in the community. So how is it possible to change all this? It needs humongous effort on part of the PMDC, the regulating body. It needs humongous effort on part of all the curriculum developing bodies, everything. But it definitely needs to be done. It definitely needs to be done. Thank you so much.
Agreed, totally agreed. Dr. Sadia, the role of Pakistan Medical Council is crucial. Faculty development is crucial. Guidelines are crucial. The task is humongous, but there are leadership is about doing humongous tasks. So if there is leadership, they should take head on these challenges and show their leadership to achieve the task. Totally agree.
Dr. Arshad next and then Shahid. Dr. Arshad, please unmute yourself. You raise your hand.
Yeah,
Where?
good afternoon, Dr. Gowhar from Kuwait. How are you? Professor
Dr.
Gowhar.
Arshad, good to hear.
Yeah, so Professor Gowhar, my question is that community-based education, but then we need the industry also to be community-based, practicing it, right? But we don't, I don't know how much, I don't know a lot about the Middle East in general, but of course I know about Kuwait. So if you could tell us that in the Middle East, if community-based medical practice, is it happening? And because we will go to community-based education only if the practice is community-based. What do you say?
Excellent question. See, the concept is very simple. Let me make it even simpler to you. If you are in Kuwait, then will you prepare any products? You take any products like cars and air conditioners or any products, they have to fulfill, if you need to market them in Kuwait, they have to fulfill the needs of the people in Kuwait. So you will not make products that are not needed in that particular community because if these products are not going to sell there. Same is the concept here. Kuwaiti government, as I can tell you, and many other governments, they have already adopted to the WHO resolutions. In fact, they are the ones who propose that we want to adopt family practice-based model of care. So when it comes to question how do we want to provide care, they say, oh, we are with family practice-based model of care. So if the product they want is family practice based, then all the physicians and nurses you are producing and you are producing them based on the disease based model of care and hospital based model of care, relevance is gone. the very first slide I showed. So if you need to fulfill family practice-based model of care, how much do you teach family practice? How your curricula need to be reformed to be family practice-based curricula? That is where education gets into alignment with the industry. So that's probably second or third slide, which I showed between the healthcare delivery systems and education system. They have to be aligned.
Thank you, Professor Gowhar. Wajid, there's a comment from Simon Batul, your old student from University of Lahore, which is complimenting and, of course, saying that the systems are not. Shahid is Associate Dean at American University of Barbados, a very seasoned scholar. Shahid, come in with a question. Please unmute yourself. This is a
Thank
good
you.
opportunity to learn from master scholars.
Thank you very much. Thank you very much, Prof. Zaidi, and thank you very much, Prof. Gowhar Wajid, for your enlightening session today. And it's always great listening you. You always come up with innovative ideas, and is not you do not talk from your own perspective, but institution behind you. That's great. Listening to you, there are a few things. Number one, a little comment on community-oriented versus community-based medical education, because this was my thesis in master's in medical education back in 2005. I give you an example. There, when we were taught for a session about community-based medical education, the lecturer came in our class and asked how many, we were 23 students from 18 countries, and she asked how many of you are from community-based medical education. So only Indonesia and Malaysia, 3 students, including me, raised hand. And then she handed over the session to us, and she said, we have, in Europe, we have hardly have the experience of community-based medical education, so you come forward and deliver this session. So that session was delivered by the students from Indonesia and Malaysia who were taught in that. Because in Malaysia, we have a very strong CFCS, which is community and family case study, where students will move. So I'm just giving the response to Prof. Zadi's community-oriented versus community-based. Community-oriented is everything that we teach in classroom, and community-based is where we take the classroom into the community. Their survey, their need assessment, or the need analysis survey are done by the students, and then families and the patients are adopted by the students, and they are taken care of. So that's the difference between when you teach community in community versus when you teach in the classroom. Now, coming to Prof. Wajid, you have mentioned is a very good strategic plan for the future for the curriculum development. And quoting back to the Lancet Commission that you said, adapting to the local needs, yet drawing on the global resources. But my question will be little critical, and I need your input. There are many schools, medical school all over the world, particularly in Caribbean island, in the Asian countries, who produces graduates, and if they are trained with the concept that you're giving, the community need analysis to be done for a medical school to be open in a community, and the students should be trained to address the community needs. But these are the students who are looking forward to serve in another country, Europe or USA, where the ACME has got different core competencies of what we are teaching them in Asian or the Caribbean islands, where the students are taught there. If they are to be brought up with a curriculum which is for the need assessment of the community there, it will be entirely a different curriculum. But what we have, so in so many words, we are producing doctors with the local need analysis of the community, and they are looking forward to serve in another country, which is entirely different. SAGME core competencies are entirely different from what the community-based competency may be. How do you see this? Are you recommending with your presentation that all those schools should be closed, or they should be, all the graduates from there should be allowed to serve in the area where they are taught? How do you see that?
There is politics in this question, there is economics in this question,
I agree. I agree.
there is strategic role of different stakeholders in this question, and there is no straightforward answer. But still, let me give you my own personal views, not any institutional views here.
Okay.
I believe in maintaining, first of all, the production capacity. So if a country has obtained a production capacity, then it should not be wasted. So no school should be closed because all of them, they contribute to the production of physicians, and there is great shortage of health professionals globally. And we don't need to recommend that we should start closing institutions, no matter whether they are producing the products for their local market or these are export oriented products. Even if they are export oriented products, they are being consumed somewhere. So having something is better than having nothing. Now, here comes a critical question whether these doctors are being produced at the cost of their own money or they are being produced at the cost of poor taxpayers. So, if, like, take my example, I never paid a single penny for my education. Who paid for it? Poor taxpayers. So I have an obligation towards those taxpayers who made me doctors, not that I become doctor and then go and start serving in the USA. I was not made for USA, but there are many institutions who carry the tag of producing export quality doctors, just like many other products, like in many countries there are export quality products produced that are produced in the factories. Nobody sees them in the country and they are just shipped to the countries wherever that demand is needed. And that is economy driven as well, because these doctors then they send valuable remittances to their country. So we leave it up to the governments of the countries on what kind of policies they want to have to improve their remittances and produce. But the fundamental thing is that whatever the doctors you are producing for your local market, they must serve the needs of the people so that they are aligned well. So that would be my very brief. This is where public-private sector debate, gets into. This would be my very brief response to your
Thank you.
reflection.
Message taken, Prof. Wajid. But one more thing to this. Um, uh, you are right, but keeping these politics and economics aside, just looking at the pedagogy and the learning aspects of it, the students who are trained in these areas, ultimately they have an aim or goals to serve, do their residency in USA, for example. I'm giving you an example, okay? So there, the to compete for the residency program, they have to unlearn, to learn new thing to compete for the residency. You know what I mean? I mean, when they are taught in a community-based medical education, and the residency program, USMLE Part 1, Part 2, or Part 3, all are addressing to have something different. So they again unlearn, then they learn to compete for there. And when they enter the residency program, again, they have to unlearn everything they have learned if we follow the community-based medical education concepts. So, in my opinion, there has to be a system producing doctors or the graduate with the local needs, and then making them to serve. You have very rightly answered. Somewhere they are serving, but unlearn to learn new things. Isn't it a waste of the entire curriculum?
I won't say it's a waste of entire curricula because students are very adaptive creatures. And if we have taught them resilience and how to be adaptive to the systems, despite the fact that we need to have the local relevance to the community needs, there is also a need to keep in mind the yet global doctors, because we are living in a very rapidly globalized world. Telemedicine is playing its role. There are technologies, the way they are progressing, those boundaries between the entire local community based needs and the striking balance between the local and global needs is they are increasingly being blunt. Think of the doctors from Syria. Just last week, I was meeting some of the doctors in Syria. They say that we take all our education in Arabic, and still Syria is one of the countries that is where the doctors are passing USMLE exams. They say we
Correct.
learn English, we prepare ourselves for USMLE, and we go to the US for residencies. So no need to, underestimate the resilience of the doctors and their learning, relearning, and unlearning capabilities.
So there are lots of compliments to you, and there is a wonderful a comment by Professor Yadullah Zarizadeh from University of Kurdistan. He says that excellent lecture, rightly mentions, sir, the importance of reflection in international education. Now, he has devised models. Unfortunately, he is logged out, and I'm hoping that he'll come back. But I have these models that he sent, and will upload on the CView platform. That goes without saying. Now, a couple of more comments. I think there's a hand, somebody raised a hand, and everybody is saying that, no, this is a comment. Can you read this? Gowhar, can you read it?
Which one? From
We have contextual factors which need to be.
yes, from Dr. Goda,
Yes.
absolutely. That he says that the key contextual factors not to be ignored. Gazira model, yes, Sudan is one prime example, and I always quote that example. Sudani doctors, although Sudani government is not in letter and spirit following family practice-based model of care, but yet diploma in family medicine is very popular in Sudan.
Mm-hmm.
Now, why it is popular? Because Saudi government is following family practice-based model of care. So they need family physicians. And that has given rise to a growing market of diploma in family medicine in Sudan, where the moment some Sudani doctor, he does 1 or 2 years, whatever the duration of diploma, they have very high chances of being taken to Saudi Arabia for the job purpose. So market demands and supply is something that needs to be kept in mind, but these are factors that are beyond the control of the then educational community. They will always remain there.
So this is, I think, where I come in, because the Jazeera model and there was Swiss model that Professor Bashir Hamad, who was my colleague in WHO, he came to Pakistan, and that is where we started. There was this project for Pakistan that was initiated by WHO, and I was the person in charge for Dow and Sindh region. We had a wonderful, I mean, he's a great, great, great teacher. I'm told recently that a street has been named after him in Sudan, Bashir Ahmad. Now, he started this Jazeera model to be applied to Pakistan. And for 3 years he worked, and I worked with him. There are many other people, of course. Kay was involved at the college. It failed for a simple reason. A, the government was not keen. And the major problem that comes up is when you go and talk to your colleagues, even my colleagues in the faculty, they became my enemies. What's the new thing you're starting, etc. That was one. The second factor was that people were not happy in sending their daughters to villages, which is, of course, understandable because the nature of things that we have. So I'll stop there, but I think I've got a couple of people before we conclude. The session has gone on for almost an hour. Umaima raised. Umaima Hamid, would you like to unmute yourself and please ask your question?
Thank you so much, Dr. Gowhar. Can you hear me?
Yes.
Thank you for your informative and interesting talk. Actually, I'm commenting for Dr. Arshad's or Dr. Shahid's concern about students who go abroad to practice in other communities that are different from the communities that they were trained in. Actually, I published a paper, an article in Education for Health journal about exploring the determinants of community-oriented health professions education. It is a narrative review. And I addressed these concerns. For this particular concern, actually, we need, as curriculum developers, to integrate the competency frameworks all over the world in our community-oriented curriculum. We must manage the tension between global and local, our local community, so that our curriculum becomes locally oriented. We have to include in our curricula also health economics, health systems science, cultural sensitivity and safety. All this makes the students, as you said, Professor Gowhar, that it makes our students resilient and adaptive to different communities that they might work in later on after their graduation. Thank you so much.
Very useful comments.
So Trifa, I think, has raised hand, and Mushir Hussain is a very senior professor at University of Dundee. So let's hear from Trifa first. Please unmute yourself, Trifa. Am I taking your name correctly because you raised your hand? Trifa, can you hear me? Otherwise, over to you, Trifa Mahmood. You raised your hand. Anyway, over to Mushir.
Can you hear me, sir?
Yes, yeah, loud and clear.
Oh, great. So thank you for the seminar, and Professor Wajid, of course. My question is, because my interest is in postgraduate education, and that also surgical, the problem with and our curriculum is completely competency-based. The problem comes with assessment, particularly of surgical skills. And so if you do a procedure, you can divide this procedure into steps, and you evaluate different steps. You can record it and evaluate it. But actually, how it's actually done is very subjective. And it's hard to have a pattern that is reproducible in all departments or all over the country or outside the country. So that's my question. How do you deal with such problems? Thank you.
Well, if Dr. Shahid is listening to this question, I think he can even answer better than me. But I would say that we need to, there are inherent pros and cons, strengths and weaknesses of any assessment system. We need to go back to the principles of assessment, that any assessment should be valid and reliable. No assessment methodology or even put together a few methodologies together even make 100% valid method of validity and reliability. But what we try to do is keep our assessment as valid and reliable as logistically possible to reflect those competencies that you intend to see. So that's how I would say. There is a famous diagram by Case Van Luton where he says assessment is equals to validity and reliability and feasibility and timeliness and contextuality and all that multipliers.
Well, thank you.
Thank you so much, Mushir, and thank you, Professor Wajid. Any other?
Prof. Zadi, can I give my input to Dr. Mushir's question as Prof. Wajid invited? Thank you, Prof. Wajid, and thank you, Mushir, for your wonderful competency-based medical education has been a struggle all over the world, particularly for the undergraduate teaching, where the competencies are more generic. But when it comes to postgraduate program, it is comparatively easier to address competency-based medical education program for the postgraduate medical education. I would say, first back in 2011, when I left one of the institutions where we introduced in master program, because I happen to come from the same specialty as Mushir is, the ENT and head and neck surgery. So there we identified in master program 42. First thing you have to do is to identify the standards. Identify the standard that you are going to benchmark your competencies, right? Second step is the learning outcome. So identify the learning outcome as you want to deliver these competencies. Now translate these competencies into EPAs. Interestable, as your question is, how do you break this competencies into small chunks for the milestones to be observed? So you break them into EPAs, and EPAs, people have given long definition. I simple 2 words: task at work. So competency at work become your EPAs. So identify the competencies, translate them into EPAs, and observe them through the milestones. Divide them, what competency they'll be learning in year 1 until postgraduate program year 4. So these are the milestones, and then sort of sign them off with your level of the training. There are 4 or 5 levels. So those EPAs will be observed through. So what we have done in ENT, 42 competencies were identified. They were translated into EPAs, and then those competencies, every competency you can't deliver in a postgraduate program. So nice to do and must do were identified, and those must do were delivered through EPAs. EPA can be one competency with multiple tasks. Those you can divide them into milestones. So I hope I have answered your question. And the other thing is about the ENT. The postgraduate program in competency-based medical education in ENT is very much established now. It has been practiced in USA and in Canada as well. So you can have guidelines from them also, how to translate competencies into EPAs and then observe them through the milestones. I hope I have helped a little bit to answer this question.
Well, you have to come to Dundee to discuss more. So Shahid, you have to
Yes,
come.
sir.
You have to come to Dundee to discuss with Chief.
Mushir is my guru. Mushir is my guru.
So
He's
there's
a wonderful scholar, sir. I would say he's a wonderful scholar.
absolutely. So let's ask Professor Zarizadeh to unmute. Dr. Zarizadeh, are you there? He's from Kurdistan, University of Kurdistan. Please go ahead. You raise your hand. Would you like to ask a question before you finally conclude? Because Professor Wajid is traveling and is currently in a different country from his base.
Yes, Professor.
Go ahead. Go ahead. Go ahead. I think you are having some technical issues. Can you hear me, Dr. Zarizadeh?
Yes, thank you very much. Do you have my voice?
Yes, go ahead. Ask your question.
Yeah, thank you very much. Very holistic perspective.
There's a delay
by Prof. Wajid. Community.
Yeah. Are you using VPN? That voice is not
based education, competency-based education, and interprofessional education with elements of reflection is very.
I think there's technical difficulty with Dr. Zarizadeh's, but he was talking about the reflections and he has sent me the files, which we'll upload. I'll ask Sakina to upload on the CViews platform. There are lots of compliments, of course. Everybody knows Professor Gowhar Wajid, of course, with the powerful people like Shahid and Mushir and so many others, Sadia Rafiq, Sadia Batur, and Sadia, who was the other one? Sadi Shahzad. So many powerful speakers and all the scholars. Is there any more comment before we finally thank Professor Gowhar Wajid, because he's traveling? And so I think that's it. Professor Wajid, would you like to say anything before we conclude?
Thank you so much, everyone. The struggle continues. This is a continuing journey. Task is not difficult, but we need to, being educationists, we need to find out the ways and solutions to address this task. But I prepared particularly this presentation about last week. I think I had a presentation in Saudi Commission for Health Specializations in Riyadh, where they were emphasizing that we need to introduce interprofessional education in our undergraduate professional curricula. So I particularly wanted to draw their attention that it's not just IPECP concept introduced, rather you need to look at the curriculum reforms holistically so that you can make all the corrections that can possibly be made in that context in our curriculum. So my take home from this whole exercise is that curriculum reforms should not be seen in silos as adding one particular module or two subjects or these small scale transitional changes. Rather, when we talk of reform, we should look holistically that these are the reforms when we bring, we will be able to produce better doctors or other health professionals. I really appreciate it. Thank you so much.
Well, there are lots of compliments. So obviously you have to come back, hopefully in the next few months, whenever you have time. Whether it goes without saying that on behalf of all the participants, and particularly Sadiq International Virtual University, no words to thank you, sir. You have been very kind, generous, and an expert, master tutor, tutor of the tutors. I've said teachers of the teachers. Absolutely wonderful to listen to you and learn so much. And with these words, over to Sakina for final announcement for the future programs. Over to you, Sakina. Thank you, Dr. Gowhar Wajid.
Thank you, sir.
Sakina, do you have to make an announcement or should we close the session? Maybe.
And thanks indeed, Prof. Wajid. I think Sakina, can you hear us?
Can you hear me?
Yes.
Okay, perfect. I am so sorry. I want to start with that. I lost track of time today between the time zones. And I was like literally picked up my phone to send a message of reminder that we will start in 30 minutes. And when I saw like a whole bunch of missed calls and messages, I am extremely sorry. It was a great lecture, Dr. Gowhar. I have no medical background, but I really, truly enjoyed it. Inshallah, we have another session next Saturday on dementia, a journey of life. Please do join us. And I will upload this amazing lecture on the YouTube and I'll share the link and any documents that I get that I can upload. I really appreciate all of you joining us and thank you so much. We'll see you
Thank you so
next
much.
Saturday.
Thank you so much.
Thank
Bye.
you and bye-bye.